Pediatric surgical oncology represents a most challenging field of pediatric surgery. Worldwide, pediatric surgeons have been dealing with pediatric solid tumors. Having said that, specific skills and additional knowledge is required to deal with children with pediatric solid tumors. To fulfill this goal, the Association of Pediatric Surgical Oncology was established in the year 2006 during the annual conference of IAPS, and this has been established as a section of Indian Association of Pediatric Surgeons. With efforts of Professor Dr. Yogesh Kumar Sareen under the presidency of Dr. K. Shrimurthy. Hi, I am Dr. Sushmita Bhatnagar, consulting pediatric surgeon from Mumbai and currently the chairperson of APSO. With the passion and special interest in the field of pediatric surgical oncology, I am on a mission to fulfill the aims and objectives of APSO along with my team. So let's meet our team.
Hello everyone, myself Dr. Basant Kumar. I am Secretary of Association of Pediatric Surgical Oncology, a section of Indian Association of Pediatric Surgeons. Currently, I am working as a professor in the Department of Pediatric Surgery at Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. I am here to aware, support and take care of neonates and pediatric patients having childhood malignancy. Please join us, support our campaign and take care in awareness of society and people regarding these sick children. Thank you.
Hello everyone, I am Dr. H.P.S. Miglani, past chairman APSO. APSO now has a new team led by Professor Sushmita Bhatnagar. I am sure the new team will take APSO to newer heights as well as generate a lot of interest about pediatric malignancies in the general public and create interest about treatment and early diagnosis of malignancies in children amongst the fraternity, that is members of Indian Association of Pediatric Surgeons. I urge all members of IAPS to support APSO to the fullest. Thank you very much.
Hello everyone, myself Dr. Rohit Kapoor. I am Treasurer of Association of Pediatric Surgical Oncology, which is a section of Indian Association of Pediatric Surgeons. Currently, I am working as Assistant Professor in Department of Pediatric Surgery at All India Institute of Medical Sciences, Raebareli. I strive to work for the betterment of children suffering from childhood malignancies and create awareness regarding this unrecognized or under-recognized entity in general population. Thank you.
Good morning, friends. I am Dr. Senthil Nagan, Professor of Pediatric Surgery, Madras Medical College, and Pediatric Surgeon, Government Children's Hospital in Moore. I am also Executive Committee member, South Zone for APSO, which is a subchapter of Pediatric Surgical Oncology for IAPS. What way our chapter can support? First, awareness of the disease is very important. Even a bizarre symptom, the attending clinician or a pediatrician or general practitioner should be aware it may be a malignancy and should make a timely referral. And we have to investigate these cases in an appropriate manner and start treatment. As pediatric surgeons, we must try to encompass all the modalities of treatment under one roof, and we must take the lead role in trying to manage these patients. As I said before, some of these tumors are essentially a curable one. You must go all out to manage these cases. This is the important message we have to give.
Hello dear APSO and IAPS members. I am Dr. Manoj Joshi, Professor of Pediatric Surgery at Super Specialty Hospital, Mahatma Gandhi Medical College, Indore. I have been elected as Executive Committee member of Central Zone, and the responsibility assigned to me by our chairman and secretary of APSO is publication, and in that context we are planning to launch a newsletter, and will require your support and coordination for that. The reason why I am in APSO is my keen interest in pediatric surgical oncology and the desire to contribute in this field of childhood cancers. We look forward as a team from the support of all IAPS members, also the APSO members. Thank you very much.
Hello, I am Dr. Santosh Kumar Mahalik. I am working as an associate professor in AIIMS Bhubaneswar. I have been elected as an executive council member in APSO from the East Zone. The key purpose for which I have been in APSO committee is to develop guidelines and create awareness for cancer in India. Hello.
Hi, I'm Monica. I practice as pediatric surgical oncologist in Mumbai. I am part of team APSO as an executive member West Zone. I request all members to support us to make it bigger and better. Thank you.
Hi, I'm Dr. Anjan Kumar Dua. I am working as an additional professor at AIIMS New Delhi. I take care of the website www.apso-iaps.com on a day-to-day basis. I urge all other members to contribute their bit to help our executive members, Dr. Basant Kumar and Dr. Sushmita Bhatnagar, to take APSO to greater heights. Thank you.
Hello, I am Dr. Nitin Jain, Assistant Professor, Department of Pediatric Surgery, Maulana Azad Medical College, New Delhi. I take care of APSO social media platforms and keeping them up to date. APSO follows the motto that the future depends on what we do today in the present. In today's world, social media plays a big role in achieving this by creating a platform that strengthens academic activities, ensuring regular training, and creates awareness. I urge all the members to help us in making APSO goals achievable. Thank you.
Good evening, everyone, and good morning, person from abroad. On behalf of Team APSO, it's my pleasure to welcome you all in this academic feast. That is our first tumor board meeting. Thank you for joining us. In today's meeting, we have a very interesting case to discuss and learn from our teachers, panelists. Panel personnel of today's tumor board are well known, renowned faculty, teacher, and stalwart personality from their subspecialties. So let me introduce them first. Devlina, can you? Yeah, please. Yeah. First panelist is Dr. Bhaskar Rao. He is ex-director of surgical department from St. Jude Children's Hospital, USA. He has a special interest in osteosarcoma, germ cell tumor, interstitial brachytherapy in the management of pediatric solid tumors, limb salvage procedures in the management of primary bone tumors, management of non-rhabdomyosarcoma, management of rare tumors, including endocortical carcinomas, and many more. He has almost 600 publications in all reputed international journals. Thank you, sir. Thank you for joining us today. Next. Yeah, second panelist is Dr. Purna Kurkure. She is a pediatric oncologist. She is chairman, Oncology Collegium, Narayana Health. He is head pediatric hemato-oncology and bone marrow transplant from SRCC Children's Hospital, Mumbai. She was previous head of pediatric oncology at Tata Memorial Hospital, Mumbai. President of SIOP Asia from 2007 to 2010. She is consultant to Subcommittee of Pediatric Oncology in developing countries of SIOP. She is the founder member and co-convener of Pediatric Hematology Oncology chapter of Indian Academy of Pediatrics. She is President Teen and Young Adult Cancer Trust 2, and she is Vice President Indian Society of Neuro-Oncology. Thank you, ma'am. Thank you for joining us. Next. Is Dr. Matthew Krasin. He is radiation oncologist from St. Jude Children's Hospital, USA. He has focus on pediatric solid tumor and Hodgkin's lymphoma. He studies radiation late effect and how modalities like photon beam radiation may mitigate these efforts. He has been member of ASTRO, COG, and APSO. He is reviewer of various prestigious journals like Pediatric Blood and Cancer and Journal of Clinical Oncology, and many more. He is currently serving as a chair of Protocol Scientific Review Committee for St. Jude Children's Hospital at USA. There are various, he has various publications too, but excuse me for not showing it here. Welcome, sir. Welcome in our tumor board. Next. Dr. Priscilla Joshi is well-known pediatric radiologist, professor and head from Department of Radio Diagnosis as Bharati Vidyapeeth Deemed University Medical College, Pune. She served as a graded and classified specialist in the Army Medal Corps. She was former consultant at Sir Gangaram Hospital, Delhi, Hinduja Hospital, Mumbai, and Jahangir Hospital, Pune. Formerly, she was Vice President of Indian Society of Pediatric Radiologists, and more important, she is a recipient of M.V.K. Shetty Oration in 2017, and she got Best Teacher Award at Bharati Vidyapeeth University in 2014. Welcome, ma'am. Welcome to our meet. Next. Dr. Reena Bharadwaj. She is a surgical oncopathologist in New Delhi, and she is professor in pathology at Bharati Vidyapeeth Medical College, Pune. She got major journals, Sena Medal and Vishish Seva Medal from Indian Army. She is president in Indian Academy of Cytologists. She is executive member and editor of newsletter for Indian Association of Cytologists, fellow of Indian College of Pathologists, but most important is contributed 5 chapters in Bird Textbook of Pathology and many more. Thank you, ma'am. Thank you for joining us. Now, without wasting the time, I invite our chairperson, Dr. Sushmita Bhatnagar, to take the proceeding further and start the tumor board. Please take it, ma'am. Thank you.
Thank you, Dr. Basant, and a very, 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 very warm welcome to all our panelists who have been from all over the world, and also our colleagues who have joined from so many places all over the country. So thank you very much. I have seen one Dr. Humayun, who's actually from Afghanistan, but he is now in Germany. So he has also joined us. It's great to have such a vast, representation from various places. So now I would like to call upon our general surgery resident, Dr. Neil Seth, to jump off with the presentation and give us all the information about the case, which we have been waiting for eagerly for such a long time. Over to Neil.
Thank you. Good evening, ma'am. Good evening to all the senior consultants. I am Dr. Neil Seth, a third-year general surgical resident under ma'am at Bombay Hospital Institute of Medical Sciences, and I'll be presenting our case on infantile myofibroblastic tumor. So this was a very interesting case that we encountered last year in February of 2022. However, the history of the child starts as the child is an 11-year-old boy who's a resident of the interiors of Maharashtra, born on 16th of November 2011. The boy had symptoms from the age of around 6 to 8 months, wherein he would have difficulty to pass stools for 24 to 36 hours. Following which he would pass small ribbon-like stools after excessive straining, but he was never truly relieved of his symptoms. They started from the age of 6 to 8 months, wherein his mother started taking him to a local doctor here and there in their respective village, and the doctors would prescribe laxatives and over-the-counter medications. Initially, the child would require laxatives at an interval of around 3 to 4 months. This went on till the age of 4 to 5 years. Following which the frequency of laxatives gradually kept on increasing until the child required laxatives almost daily, till he had an episode of which we're going to come to. Coming to 2021, when the child was 10 years of age in November 2021, he had his first episode of major hospitalization. child complained of sudden onset severe pain in abdomen with inability to pass stools or flatus with severe abdominal distension. Going to the same local doctor who had been prescribing laxatives, looking at the condition of the patient, the doctor said he had to be taken to a larger hospital. He was taken by his mother to the nearest municipal hospital, wherein after some preliminary examination and x-rays, he was diagnosed as a distal colonic acute intestinal obstruction. Conservative management was opted and tried for around 24 hours, but looking at the child not settle down, the child was posted for an emergency laparotomy and a transverse abdominal incision was taken. The findings that were seen were a dilated ascending and transverse colon with a very hard and suspicious mass that was felt in the pelvic region that was thought to be arising from the wall of the bowel. Looking at the mass that was very inseparable and stuck to the lateral wall of the pelvis and everywhere, a decision was taken just to perform a loop sigmoid colostomy and a biopsy of the mass was done. Once the child settled down from the acute episode, the decision was taken to evaluate that mass a little more. So consequently, the child underwent a CECT abdomen, wherein a neoplastic mass involving the lower rectum and the anal canal with the circumferential thickening of the rectosigmoid junction was seen. Unfortunately, we don't have the films of this, but however, as the CT did not give too much information, they went for an MRI pelvis. So the MRI pelvis showed an altered signal intensity mass of 3.7 by 4.3 by 5.3 centimeters, lying on the right of the rectum, extending lower down to the left of the anal canal. Also, with loss of fat planes with the urinary bladder extending into the presacral space and invading the right lateral pelvic wall with loss of fat planes with the obturator internus muscle. Once the histopathology was available, it showed inconclusive report suggesting an inflammatory tumor with the possibility of solitary rectal ulcer syndrome that was given in their report. However, the slides were not available as this was done at a far-off hospital. However, the report did mention no evidence of malignancy. Fast forwarding 4 months, the child was referred to Mumbai and presented to us in February 2022. When the child presented on examination, as we can see in the image, there was a loop sigmoid colostomy in the left iliac fossa, which was functioning well. However, a very interesting finding we had was a palpable mass in the hypogastric region, which we initially thought could have been an extension of the tumor from the pelvis, but was later found to be just a feculoma in the distal colon. Coming to the PR examination, there was severe narrowing of the anal canal, admitting only the tip of the finger with a hard mass palpable in all the directions. Also, an interesting finding was on PR examination, there was a hard mass palpable somewhere around the left istiorectal fossa, a little closer to the anal canal. When we started investigating the child, the routine blood investigations and urine routine were normal. A USG abdomen with pelvis was done, which is shown in the image. Here we can see the mass lying in close relation to the bladder. However, USG did not show the mass abutting into the bladder. It was a 3.7 by 2.1 by 2 centimeters hypoechoic mass along the right side of the rectum. Later, a CT was done in the same month. The CT showed a mass in the right pararectal region with its size that was unchanged from the scan that was done outside, and it was seen abutting the right. Abutting the right vesico-ureteric junction and the right seminal vesicle. As we can see here, it's in close relation to the right caudal part of the bladder, that is the trigone and the right seminal vesicle and the vesico-ureteric junction. Then it was seen to extend along the lateral wall of the anal canal on the left side. As we can see here, it's involving the left side of the anal canal as well, and abutting the puborectalis sling and the left external anal sphincter. There were multiple enlarged external iliac nodes as well, with the largest nodular component measuring 3.5 by 2.3 centimeters. Histopathology report, so CT-guided biopsy was planned, and the CT-guided biopsy was done from a posterior approach, and multiple true-cut biopsies were taken. The report showed a dense hyalinized collagenous tissue with fibroblastic and myofibroblastic spindle cells and scattered lymphocytes and plasma cells. So the report was suggestive of either a spindle cell tumor. However, the possibility of an inflammatory myofibroblastic tumor could not be ruled out. Here we can see a 10x image and then a 40x image. So once we had this report, we thought surgical excision of the tumor would be the best approach to deal with this. So a complete excision of the tumor was planned from a posterior sagittal incision. Once the posterior sagittal incision was taken and the tumor was approached, however, the tumor was extremely hard and it was very adherent to the surrounding pelvic structures like the anal canal, the rectum, the urethra, the prostate. Also, it was completely stuck to the presacral space and the sacrum, and even to the lateral pelvic wall, so adherent that we were not even able to get our hands around the tumor or even lift up the tumor from any structure. So looking at the overall condition, the decision taken to excise the posterior most part of the tumor and send the specimen for histopathology. So consequently, that was done. Here we can see the approach to the tumor. And this is once we reached the tumor. And now a few images of excision. This was a piecemeal excision of the tumor that we could achieve. And it was a considerable amount of tumor, as we saw in the CT scans later. The histopathology report, when arrived, showed fibrocollagenous tissue with fibroblastic cells between the smooth muscle cells of the bowel wall. Part of the rectal wall was also removed with the tumor, and inflammatory infiltrate with lymphocytes, plasma cells, and lymphoid aggregates. So differential diagnosis of an inflammatory myofibroblastic tumor or an IgG4 sclerosing disease was given, and immunohistochemistry was advised. Postoperatively, patient recovered well and was discharged after 1 week. Fast forwarding to November 2022, when the patient returned to us and was readmitted, this time the patient had a nodular lesion in the mid-incision site and a large feculoma in the distal colon. From the incision site, there was mild staining of pus and occasional fecal matter on and off. So multiple washes were given from the distal loop of the stoma to try and evacuate the feculoma, but the feculoma was very hard and was not evacuable with just washes. So evacuation of the feculoma under general anesthesia was done, following which conservative management with sitz bath, antibiotic ointment was given, and the discharge subsequently stopped in around 2 to 3 weeks. Other clinical parameters were maintained, whereas the PR exam, the anal canal was just as stenosed as it was before. Then another USG of the abdomen and pelvis with a transperineal scan was planned. There was a similar mass in close relation to the bladder. This time the mass showed high vascularity on USG as well. Here we can see the space occupying lesion lying very close to the bladder. And here we can see the Doppler image that is showing good vascularity in the tumor. In the transperineal scan, the tumor was extremely close to the anal canal and invading into the anal canal, as we can see here. Also, the Doppler image shows similar findings with the anal canal, the tumor almost invading into the anal canal. A CT scan was repeated, which showed post-op changes in the perineum with a bulky residual lesion encircling the rectum and the anal canal. However, this time, the size of the lesion was reduced to 3 by 2.7 centimeters, and it was seen abutting the trigone, the right vesicular junction, and the right seminal vesicle and prostate as before. However, there was a subsequent reduction. There was a substantial reduction in the size of the tumor. The immunohistochemistry, as advised before, was done, and the report showed a positive staining for CD138, which showed plasma cells, and very occasional plasma cells in the IgG4 staining, with a negative staining for MIC2 and desmin. So the report was suggestive of an inflammatory myofibroblastic tumor itself. Now in December 2022, looking at the patient and looking that surgical options would lead to lifelong morbidities like a permanent stoma and urinary diversions, impotence, infertility, as the only way to get this tumor out would be a complete pelvic exentration. So discussion with the pediatric oncologist of our institute was done, and the patient was planned for chemotherapy. 4 cycles at weekly intervals of 5.1 milligram vinblastine with 25 milligram methotrexate and tablets of celecoxib and tamoxifen was given, which the patient tolerated well. A CT scan was repeated after the chemotherapy. However, the CT scan showed no significant improvement in the size or extent of the tumor, and the invasion of the surrounding structures was also the same. So you can see in the scan given here. Coming to the clinical examination, on PR exam also, the findings had not changed much post-chemo as they were before chemotherapy. So looking at the advancements of the disease, a local tumor board meeting was held, and after consultation with the radiation oncologist, a decision was taken to start the patient on low-dose radiotherapy. A 3-dimensional conformational radiotherapy with daily imaging was delivered to the pelvis. After 14 cycles of this radiotherapy, however, the discharge from the midline posterior wound had started again, and the patient had significant pain because of the radiation-induced dermatitis. So because of the discharge, the radiation was stopped. Then to look at the progress that had happened in these 14 cycles, we repeated a CT scan in February. That CT scan did show a mild reduction in the size of the tumor with hemorrhagic and necrotic components, with bladder wall invasion probably due to post-radiation tissue destruction. As we can see here, there are a few necrotic components in the mass, and here there is invasion of the bladder wall. Coming to March 2023, once the discharge had dried up again, the radiotherapy was completed with a total dose of 54 gray in 30 fractions was given over 30 cycles over 41 days. Post radiotherapy, a PR exam was repeated and it showed radiation dermatitis, as we can see here, which was expected. However, distal 2 phalanges of the finger were negotiable in PR exam, which showed a considerable lessening or reduction in the stenosis of the anal canal. This was a nodular lesion that was mentioned with some antibiotic ointment applied. CCT was repeated after 30 cycles of radiotherapy, which has shown minimal regression in size and minimal reduction in the size of the external iliac nodes as well as the bladder wall thickening. This was as compared to the scan that was done after 14 cycles of therapy. So this is a comparative video of all the CT scans that we have since the first day that the child presented to us. So the scan that is seen here is the first scan that was done in February 2022. The scan to the left of it was the scan done in November, which is the post-operative scan. The scan on the right is the post-chemotherapy scan. And this is the mid-radiotherapy. And the first scan that we can see is the latest scan that has been done after 30 cycles of radiotherapy. So I'll just play this video. So here we can see the mass in all of the scans. These are a few images taken at different levels, comparing all the 5 scans together. So you can see in this scan, this is the first scan that was done pre-operatively, and the size of the tumor to the left of the anal canal as compared to the last scan has significantly reduced. Also, in the scan that is a little lower down, the cut that is a little lower down, we can see just a collapsed distal colon here in the first image, whereas in the last image, there is a little bit of the lumen of the anal canal as well that is seen with the collapsed distal colon here, which was also confirmed on clinical PR examination with allowing the distal 2 phalanges of the finger now as compared to just the tip of the finger when the patient presented. Thank you.
Dr. Neil very well presented and very articulated, and all the information that you have provided. Now this case has been presented not because it is a rare event, but also because it is a very difficult situation to manage this. Before we start discussing the tumor, I digged into some research, meaning some articles, and I found some interesting facts which I would like to share here. This was a report in Journal of Pediatric Surgery in 2011 of inflammatory myofibroblastic tumor of the rectum in a 13-month-old girl, a case report. And here it was mentioned, yes, the presentation that we have had, which is not just the rectum. It is not excisable because of the location, and it is engulfing the entire rectum and the anal canal on all sides, as well as infiltrating into the prostate seminal vesicle. So the situation that we are in is a bit different, but here they found only one such case in the literature, and that was in 2011. So there has been another article, rectal inflammatory myofibroblastic tumor in 2021. It was published by Jung Hoon Ho. So here they have reported only 8 cases of rectal IMT, and this is the one they are reporting is the 9th one. So I thought maybe all of them are adults, but then when I looked into the details, there are about four patients of these 8 or 9. 4 of these 9 have been pediatric patients, but again, not as small as this. So basically what we are looking at is something which is extremely rare, something which is in a very difficult situation. I mean to say that in a very difficult location for management. So by the time we have some questions from the from our esteemed delegates, I would like to just touch upon some of the features of the inflammatory myofibroblastic tumors. So can I put my query across to Dr. Joshi, Dr. Priscilla Joshi? Hi. So was there a possibility of diagnosing this tumor without surgery? I mean to say without biopsy. Are there any radiological markers on imaging to differentiate this tumor? Because some of the tumors have some marking. So that is the reason I asked you.
So looking at these images which are there, of course, they are post-operative and follow-up on radiotherapy. I don't think we would have been able to call this infantile or inflammatory myofibroblastic tumor. We would think of other differential diagnoses which exist in this age group. One could have thought of an rhabdomyosarcoma, probably the closest DD as far as imaging goes, not on pathology or otherwise. Then other lesions like desmoplastic small round cell tumors and lymphomas also could have been a possibility. Findings which they say, I've never seen a case so far, this is the first case we've seen, is that these are usually solitary. They are well-defined, heterogeneous, solid, hyperechoic lesions on ultrasound, and they show a fair amount of vascularity, which our lesion is also showing. They can have either well-defined or ill-defined margins, and they are known to infiltrate into the surrounding structures, as is in our case. And on CT, which is the investigation of choice in children, despite the radiation dose which it involves, these lesions show a fair amount of contrast enhancement depending upon the composition of the tumor, how much myxoid and how much fibrous and how much inflammatory components are there in it. And depending on that, the contrast enhancement can be either early, delayed, or even absent. Calcification is very rare in these tumors, and they are known to be aggressive with circumferential involvement around vessels, bowel, mural infiltration, and ulceration. So yes, if you read the description of the lesion, you would say, yes, our lesion fits in with that, but I don't think at first glance I would be able to call it an inflammatory myofibroblastic tumor.
Thank you, Joshi madam, because many a times biopsy and the reports of the biopsies are delayed to a great extent, and that is the reason of me asking this question, so that we are able to kind of handle such situations in the future as well better.
It would be a differential diagnosis with the other tumors which I mentioned to you.
Yes, got it. Yeah. So Reena Bharadwaj madam, we would like your inputs on this inflammatory myofibroblastic tumors and whether the infantile variety is different from those occurring in older children. Okay, so we would take this discussion to the surgical aspects. Rao sir, we would love to hear from you, your surgical experience of these tumors, especially whether you have been able to completely excise the tumors in all your patients.
I mean, with so many years, I've assisted only in 2 cases and done myself one when I was at Sloan Kettering. That's almost 30 years ago. After that, I've not seen it. I don't think we've seen a case in St. Jude, as far as I know. I don't believe in all 3 cases we had a complete resection. None of the patients I know of, at least, remember, had any chemotherapy, but had radiation for whatever it's worth. Now, both the patients at Sloan Kettering, I have not even to follow, so I don't know the results of what they're doing now, whether they recurred or whatever. So the follow-up I can't give. But talking to people that have had experience, everybody says that the most they've had it in one or 2 cases at the most. So it's an extremely rare tumor. And the question, of course, is you have a different age limit there in India. It's 15 years old is your pediatric surgeons, and we see kids. So we see children even up to the age of 21 or 25. So they still come under the pediatric department, surgical department. So the age limit, I think, for us is different.
Yes.
The ones that I've seen have been in the late 18, 19, or 121. I think one was 21 years old. But none of this in this age group, 11 years old, I've seen anybody. And so the question, the way that this is behaving, I would call it an intermediate grade, question mark. Is a low grade, intermediate grade, or high grade, because it's behaving very, very aggressively, coming back within 3 months after treatment of anything, even after radiation therapy and everything else. So I don't know what else you can do. I think you've done your best so far. And unfortunately, the tumor is getting ahead of you. And the only surgical option would be something that the family will not accept.
Yes, that is true, because the first thing I thought of, IMFT, as we all know, is a surgical tumor. I mean to say that surgical excision is the treatment of choice. Chemo and radio are, not always effective. Most of the reports say that the results of therapy, the chemotherapy and radiotherapy, which Purna madam will actually be able to throw some more light on this. But other modes of therapy have very limited effect. Because of the location and because of the morbidities which the parents are just not willing to accept, we literally went ahead and hoped that the tumor will at least reduce in size, or at least become a little less hard, so that even if it becomes necrotic, then it is easier to excise it. But it is like completely engulfing with a very, very thin lumen of the rectum and the canal. So here the situation is a little different. So Purna madam, we would love to hear from you. Please throw some light on inflammatory myofibroblastic tumors and your experience and the chemotherapy protocol and whatever else you can tell us.
Ma'am has to unmute herself.
Yeah, please unmute, ma'am.
Evelina, can you unmute?
Sure,
madam?
sure.
Yeah.
I have unmuted.
Yes,
Good evening, Dr. Sushmita and all the APSO members. I really welcome your move towards getting more pediatric surgeons involved in this very niche area of pediatric surgical oncology, where we generally follow the principles of surgical oncology as applied to very peculiar situation in children. And we have to remember, as a overall, I am just talking, that we have to understand the disease as a whole to really do justice to the child in a holistic manner. So fortunately, all tumors which occur in children, they are highly chemosensitive. Most of them, many of them are embryonal tumors, and they come to rescue of the surgeons to make the life of surgeons more easy by giving neoadjuvant chemotherapy. So many of the situations we are all used to that kind of tumors. Some of these soft tissue, non-rhabdoid soft tissue sarcomas, they really pose a challenge. Particularly this myofibroblastic tumors, whether they are malignant or benign, that is, it starts from there. It is a question mark. And many people associate with repeated infection and so the cause is unknown, but it is maybe an exaggerated response to and an immunological response of a host to an infection like EBV also. So there are many propositions for what has caused this and whether it is benign or malignant. That is to begin with the question. but it is a proliferation of mesenchymal tissues, mainly the fibroblastic and myoblastic lineage, but they are more benign, and that is how they don't respond to chemotherapy. So the surgical option is the best option, as we all know, in these tumors. If you are able to remove it surgically totally, then you achieve cure without any problem. If you have a situation anatomically, if the tumor is located, say, in this kind of a situation, pelvis, perineum, retroperitoneum, involving major vessels and structures around it, the surgery is a challenge. But I don't like many of the time when the parents ask whether how malignant, or when you diagnose it, they are very happy that it is not clear-cut malignancy, but they don't realize that this is much more difficult than a malignancy to handle. Nowadays, what we do is we do many of the biological markers, like they are supposed to be ALK positive. And this ALK positivity can we do have an access to drugs which are targeting this receptor, and you can use ALK inhibitors, crizotinib, lorlatinib, and that targeted therapy perhaps is the way to go, because chemotherapy in a tumor which is non-replicating means we all know that this is all more of a mature form of the spindle cell tumors, and they don't respond because they are not replicating. They are all in a quiescent phase, and you will do more harm than doing good. Means you are not achieving anywhere. So I think the most important thing in this is to do the molecular workup. And the most important for myofibroblastic tumor is ALK positivity. And if it is ALK positive, then we can, it makes it very comfortable for a surgeon to do surgery also. I'm not too sure in this case because of the pelvic location, but I remember one case which was there in liver. We saw infantile, that was a child under 1 year of age, and a huge mass just in a just above on the superior surface of the liver, and it was growing in thoracic cavity, like it was pushing the diaphragm very. Child was absolutely cachectic when he came, and fortunately for him the ALK was positive. We gave the crizotinib, and the mass shrank, and we could do the surgery, complete surgery. I'm talking my experience at SRCC, the current one. I don't remember many, but the surgery is always a challenge, and this markers, molecular strategies is the way to go forward. And today the child is fine after 3 years from first surgery. So surgery is the mainstay. How you get to there, how you get to be able to do the surgery, that is the aim of all our efforts.
Absolutely, very well said. The ALK, I think many of them in the chat also are asking whether what is the ALK report. So ALK has not been done, honestly, due to funds which were not.
No, the ALK is very simple. I think basically you do ALK, and then if like now you have a first generation, even second generation ALK inhibitors are available, so you can utilize them, and that would be the right way to go.
Yeah, we can hope that it is positive, because if it comes negative, then what do we do?
But ALK should be done, and also the TRK A, B, and C. That because we have this MAP kinase and other pathways which can be explored for the treatment of such difficult diseases, rather than using modalities like radiation, which is not taking you anywhere. If we are worried about the surgical mutilating surgery, we should be as well worried about the radiation. So these two are, so I would suggest that we do the ALK at first and try to utilize the drugs which are now available to the advantage of this child.
Great. That's been very, very.
And I have seen this in front of my eyes. Like, it was such a difficult thing, but it could be excised and the child is fine. So only surgery is the answer. How to make them amenable to surgery is the way to go for.
Absolutely. Thank you so much, madam. Over to Reena madam. Reena madam had logged out in between. I think there were some network issues. And I must also thank Reena madam, especially because she has been very, very unwell since morning. She's having high-grade fever and sore throat and all. But still she said, I will be there, even if I'm not heard very well or whatever, but I'll be there. So over to you, Reena madam.
Good evening, everybody. Sorry for that technical glitch. To begin with, the first biopsy said solitary rectal ulcer syndrome. Solitary rectal ulcer syndrome is not seen in children. It's a tumor which is seen at 60 plus. And it shows classically diamond-like glands, which are not mentioned in the histopathology report. As far as I can see, it's just an infective inflammatory ulcer. Dr. Sushmita, if you could just bring out that presentation, I'll repeat what Dr. Purna has said. It's exactly in tandem with what Dr. Purna said, but I'll just, because pathology is abstract, it'll just make it clearer.
Right.
So inflammatory myofibroblastic tumor for a pathologist is not so uncommon. It was first described in the lung, but it is seen in every organ today. And depending on the morphology, it has multiple names. If there are lots of plasma cells, it's called plasma cell granuloma, plasma cell pseudotumor, so on and so forth. But the term IMFT is the preferred term. Initially, it was thought to be borderline and locally invasive. And there is a component of Mycobacterium avium intracellular in the etiology. It classically shows elevated ESR, anemia, thrombocytopenia, and hypergammaglobulinemia. I don't know, the gross was not mentioned, but they're usually lobular. They can be single lobules or multilobular. They're very hard, as was in our case. Now, the tumor can have three types of components: spindle cells, plasma cells, and lymphocytes, and the stroma, and it passes through these three phases. So first, the spindle cells come. Then the plasma cells become more prominent, as you saw in our case. And then the stroma becomes completely hyalinized. And if it has an epithelioid morphology, it's called epithelioid myofibroblastic fibrin. Can I have the next slide? So in these tumors, you get all smooth muscle markers positive. As ma'am said, they're supposed to be immunoreactive for ALK. Dr. Sushmita, our case was ALK negative.
No, we haven't done it only.
No, the report that you sent me, it says the cells are negative for ALK. So as ma'am said, there are clonal molecular levels where you have translocations of 2p23 and N-Turk fusions. So I think molecular will be the answer. Also to say that some IMTs can be ALK negative. Next slide, last slide. So as I said, when the spindle cells are more, it looks like a leiomyosarcoma. When the plasma cells are more, it looks like IgG4 sclerosing disease, which is of which a part is idiopathic retroperitoneal fibrosis. So honestly, I think IgG4, the presentation is very much like IgG4, but her markers have not come positive. So we really need to go back and look for eosinophils and endophlebitis. This is the vascularity, where the vessels get organized. And IgG4 was also negative, unfortunately. So everything was negative. The last slide, please. The presentation is more like an IgG4. ALK is negative. So we have to go for molecular. The spectrum is large from reactive conditions to IMT. They were supposed to be pseudotumors, but today, especially abdominal and retroperitoneal, are neoplastic. And in fact, they're called pseudotumors because they are known to have a metastatic potential. So our patient, now the etiology is probably infective trauma or radiation or probably tuberculosis. So we need to see if we can pinpoint any of these. That's all I have to say. Thank you.
Yeah, so I think in the chat that's happening on the side in our discussion here, you know, our approach here at St. Jude for these unresectable IMTs has usually now moved towards testing by FISH for ALK and then also for NTRK fusions, because there are two targeted agents that we've talked about, both crizotinib as well as larotrectinib, which can be used in TRK fusion positive cases. And these have very, very high response rates and can often facilitate then a margin positive surgical resection, which would be acceptable. I think in our case here, if there isn't an option for obtaining those agents, because they are very expensive, using vinblastine methotrexate, which you did, or other sort of standard sarcoma therapies like VAC, vincristine, actinomycin, cyclophosphamide, or some of the European regimes like IVA would also be considered reasonable. And we've used those in the past before the molecular era. Ultimately, like everyone has said, the ideal approach is a complete surgical resection. I think a margin positive surgical resection would also be acceptable, because there is some literature that suggests some kind of response even after surgery. These can kind of self-resolve. And then lastly, with radiation, which I have not personally used because we've had these other agents available, most people report sarcoma doses like you used here in this particular case. So in that 50 to 60 gray range, with somewhat mixed effects, similar to what we see with desmoid tumors in children, to where you can see some responses in these kids or some delay in progression, but oftentimes, ultimately, we will see recurrence again. So.
All right, that's so let's now revise our strategy as everyone of us is feeling. But before the strategizing and the summarization, we would like to take up the questions and comments from the audience. And if anybody would like to speak, please raise your hands. Over to you, Dr. Santosh and Dr. Basant, for questions from the audience.
Ma'am, before going to Santosh for audience questions, I have a query because I am also learning from experts. I want to know, is ALK or any other molecular tests or molecular markers, they have any clinical significance, especially after partial excision or excision and local recurrence in regard of that? Anyone, sir?
Yes, if we have not done the ALK and anti-RK so far, it should be done. And when there is a recurrence, now you are up against the wall as to what next will you offer. And then you have a situation where you can treat the child. Otherwise, this child will be symptomatic and miserable for not a malignant, and it is very painful because these are not really malignant tumors which metastatize and cause an end of life situation. They are otherwise fine, but they are in pain, they have the local problems, and that is very, very disturbing to child and the family, and to you also, because they have many symptoms related to their location, anatomical location. So it is worth doing it, because even in a recurrent settings, if it is positive, it will work. And today you have many options available. So I think we must explore that.
Okay, ma'am.
To improve the quality of life. Otherwise, what are you going to do with this child who is symptomatic in front of you?
Okay, ma'am. Thank you. Thank you, ma'am. Now, Dr. Santosh, you can go for questions.
Good evening, all. There are a few questions, and mostly in relation to ALK positive or negative questions like Dr. Manas Kalra from Gangaram, he initially asked like whether it was ALK positive or not, and he also in a separate message shared that if it is a targeted therapy with ALK inhibitors is excellent in some cases. That we have already discussed here. And next is Ankur Mandalia from SCBJ. He is asking difficult and interesting case. Why was chemotherapy not started immediately after surgery, as there was significant residual tumor? Ma'am, do you want to answer that? Dr. Sushmita?
So immediately after surgery, the patient is not from Mumbai. When he had come, it was already by the time he was operated, and all of these biopsy reports and all biopsy reports had not even come in by the time he had gone. And plus it was not an option to begin with, meaning chemotherapy was not an option to begin with. So with the histopath report, he was called after 3 months. Obviously, all the previous reports did not show malignancy. If it was malignant or even intermediate variety or even a slightest indication of malignancy, chemotherapy would have been given. Chemotherapy per se is again, madam has already said that this is not like a malignant tumor which resolves on chemotherapy. So, even for radiotherapy, we have waited, discussed, come out with any other option, but we didn't find any other option. So that is why some reports were reviewed, some literature search was done, some people had some benefit, and that's how we have progressed.
Yes, ma'am, I agree with you. And we are surgeon actually, and we don't know what kind of chemotherapy we need to give the patient, and especially in smaller centers or where pediatric surgeon is working alone.
Yeah. And Dr. Mohammed Mokram Ali, he asked like similar thing, like IMT is highly non-specific clinically and radiologically. IHC is only diagnostic and ALK is important IHC marker, he says. And next is Dr. Madhu Ramsundaram. He's asking about what is the final prognosis of this child with significant residual tumor. So regarding prognosis, whether Dr. Purna want to say anything? Because there is a highly residual tumor and it's not responding to chemotherapy and radiotherapy.
No, the prognosis wise, it is, as I said, the quality of life will be very poor unless and until we are able to actively intervene and decrease the tumor and decrease the symptoms. It is not going to be a straightway a tumor which rapidly increases like any malignant tumor and kills the child. So this is a problem with this kind of tumor. So prognosis in terms of ultimate outcome will be over a period of long time. So that is it's not good prognosis because it's a chronic, retracted, absolutely long duration. I would ask Dr. Bhaskar Rao's opinion also that what would be your take on the matter, because the quality of life will be very poor with this existing tumor around.
You're asking me what surgical approach can be done?
Overall, how would you, what is the, for this child, how it will go?
I mean, so far you have done everything, and we feel, I mean, like, I think Dr. Bhatnagar also feels that an accentration may be the only option from a surgical point of view, which is totally unacceptable in our community in India. The second thing that I'm thinking, and I'm thinking aloud now, okay? I'm just thinking aloud, is any thought given to embolize? Do angiogram, see if there is any major arterial supply, embolize somewhere along the line. It is not that much of a risk from a surgical point of view. I mean, does not entail exentration, major surgery. but see if it will work. You don't, I'm feeling you may not lose anything if it works, even for some time. What do you think about it? Anybody?
The angiography was not done, but as you suggest, we could even, we could do that and then assess as to what can be done about the embolization part.
I mean, just a real thought only. I'm thinking aloud. To give some options where there are not very little options available. Apart from imaging.
I read a comment about excising one part of the seminal vesicles and sacrifice right seminal vesicle, lower ureter with reimplantation. So your incomplete excision with this, it would be, I would like to say, Dr. Mukul, that it is going to be extremely difficult to even identify which is the right seminal vesicle, which is the left, and even prostate would be just so engulfed with the tumor that differentiation between the tumor, prostate, and all these structures is not going to be possible.
Yeah, ma'am.
Because the first surgery itself, I could not differentiate between the rectum and the tumor. Yes, I know, Dr. Mukul, you can even talk loud. Just thinking loud is not. Deblina, can you unmute everyone in the room, please? So whoever wants to talk, Dr. Radhakrishnan also wanted to talk. So quickly in next 5-7 minutes, we can, whoever wants to speak, they can speak and we can come to some conclusion.
Yes, ma'am, and our requests have been sent to all the doctors who have joined, and currently we have restricted that unmute.
Can I say something? I'm Radhakrishnan Satishan from Apollo, Chennai.
Yeah, boss. You can go.
Fortunately or unfortunately, I've had the pleasure of operating on 5 of those over the last 5 years. And one of them was extremely difficult around the engulfing the completely around the renal artery. This was probably my first one. So I just bailed out, took a big biopsy, sent for frozen, looked like an inflammatory myofibroblastic tumor. And then we waited for the thing and we asked for ALK, and the ALK was positive. We put on crizotinib. The child is now about 4 years down the line, is doing fine. And actually, we didn't know when to stop the crizotinib. Okay, now that becomes a problem. But radiologically, it had almost melted away completely. So we stopped the crizotinib, and the child has been off crizotinib for a few months now. And about 2 or 3 months back, when she had come on the ultrasound, there was no lesion there. That is one. I had a small bowel, not a small bowel, a sigmoid obstruction from inflammatory myofibroblastic tumor. Thankfully, nothing like what ma'am had, just segmental resection anastomosis. And it was like a R0 resection, no further treatment. I had one in the mesentery. Again, stupid or lucky, R0. Then I had one in the lung, left lung, and I had to do partial pericardiectomy on it. And that child was ALK positive. So he's on crizotinib. It was like I couldn't say it was an R0 resection. So he's on crizotinib now for the last 6 months, or maybe a year now. So that's my experience. And I think we are also looking for enteric. This far in the last 2 ones, we haven't seen any enteric rearrangements. So we haven't had to use any enteric inhibitors this far. Yeah. But crizotinib, like Purna ma'am said, works like a charm. I mean, in ALK positive tumors.
Right. Yeah. Amazing.
And
have so many patients.
And one more thing that how I would have managed this slightly differently is like you got the core needle biopsy. I know you didn't ask for ALK at that point of time. If it were ALK positive, I'm just thinking, okay, if it were ALK positive, what if you had put the child on crizotinib and then reassess later down the line, and maybe it would have been resectable.
Yeah, I know. If it was ALK positive, even today I would have been happy. by the end of this meeting.
You still can look for enteric rearrangements.
Yeah, I'll do that. I'll do that.
Yeah, ma'am.
The ALK negativity on fish doesn't mean you can still do by the fish work. See, immunohistochemistry is not a foolproof. You should do the fish.
We do fish, ma'am. We do fish.
No, that Dr. Sushmita says that it is negative. It may be negative only on immunohistochemistry.
Yes,
but
yes,
that is not the
fish.
flow. So you should do the fish, and then it will be.
If required, even NGS, ma'am. Intrec and ROS and all are new markers which come up in NGS.
So you should do that, because that is the only salvage for this cell.
Great.
Ma'am, when to stop chemo?
Chemo has no meaning. You can stop it today.
Stop.
When to stop, ma'am? How many cycles?
What? Chemotherapy, we said, no, that it has no role. And that is why we should go for this alternative
targeted
approach.
therapies. Yeah, targeted therapies.
Dr. Basant is main for target therapy only.
Target therapy.
Target therapy has to depend on the one is they look very simple, but tolerance, it depends on the tolerance to the child plus the response. Depending on that, if there is a good response and child is tolerating well, we can go on and keep on evaluating for the more definitive surgery or more definitive therapy. Otherwise, we can just continue that. There is no cumulative toxicity and so on of a targeted therapy.
Just one query, madam. Is there a point of going for a resection when on imaging you are quite clear that arterial resection is not possible? You are not going to.
I would say that, see, when the it is difficult, like in a rhabdomyosarcoma in this area also, Dr. Asiksha, if she's still on the he's still participating, then he would remember we had an excellent response in this thing, rhabdomyosarcoma in the perineal region, and child underwent radiation also, because that was indicated after explaining, because they would not agree for the surgery. But unfortunately, child had a local recurrence, and their parents did not agree.
So basically, RMS is a radiosensitive tumor also, ma'am. But
despite that,
IMT is not a radiosensitive tumor.
Correct.
And where we suppose it is not resectable and parents is also not going out for resection, is there any metronomic therapy available?
But this is metronomic only, no? When you are giving the biological therapy, targeted therapy, there is no cell kill. It's modulating the cells and the environment.
But it is very
so
costly.
It is not a cytotoxic thing. No, it is not very toxic, this thing, no? Because the dose required will be so small, so you can still manage. That's what I'm trying to tell you, that it is not a, we are not used to it. We are not used to it, and we don't bring that upfront. That is why I'm debating on this point again and again, that it should be considered.
Thank you, ma'am.
In pediatrics, we don't use. In adults, nowadays, all difficult tumors, they will just find NGS and all those markers upfront only and try to prolong this survival with the help of a simpler, manageable treatment.
Can I make one closing comment from my side, and I'll shut up, which is that, see, it tells you the importance of, from the primary care setting on, okay, of awareness of these things. Now, this child has been having symptoms since your resident presented it beautifully, since 4 or 5 months of age. All right. This hasn't grown overnight to this size.
6 to 8 months of age. It's been there for almost 9 years.
Yeah. So what I'm trying to say is these things should be taken seriously at the primary care level. You know, a simple digital rectal exam may have helped, may or may not have helped, but, you know, sending up the chain to somebody who is better equipped to deal with these things early makes a big difference. I mean, this is for everything. I'm not talking just about this child. So I think that should be something that as APSO that we should be looking to convey to the general population and general the primary care setup. That's all I have.
Krishnan, thank you for being with us.